Great. Well, thank you everyone for coming. I'm Michelle Henshaw. I'm work at the Boston University Henry M. Goldman School of Dental Medicine in the Department of Health Policy and Health Services Research. I'm a professor in the department, and I also am the Associate Dean of Global and Population Health. And the NIDCR asked that I talk a little bit about the importance of oral health research in total health care, but also to really share my path and how I got interested in research and how I found my way to doing research really almost full time. So thinking about why oral health research is important to total health, I think everyone on the call understands that oral health is part of overall health, and so their oral health research should be really incorporated into total health care and overall healthcare research. And it's really important, especially from the work that I do and what is my passion, which is trying to address oral health inequities, that just looking within the dental realm isn't going to be the answer, where we have only 65% of adults and 80% of children accessing dental care annually. And those who don't access dental care, we know, are those that are more likely to experience oral health inequities. And so using total healthcare and the healthcare settings, and also other community-based settings are really important access points for interventions aimed at improving oral health equity, as well as really focusing on interdisciplinary collaborations is going to be really vital to making a large impact, working together with our colleagues that are also addressing other diseases that have similar risk factors to oral health diseases. We don't need to continue to work in silos. If we work together, we will, as I said, be more efficient and have a larger impact. So now taking a step back and just talking a little bit about my path, which I went to college wanting to be a dentist. Definitely didn't see myself working as a faculty in a dental school, never mind doing research. But it was like little seeds along the way that actually, I think, brought me here. So the first was when I was in college. I was a work-study student. I needed to find a job to help pay for my tuition. And looking through what the opportunities were, working as a research assistant seemed much more exciting to me than, doing the front desk at the dorm or working in the library or the other jobs that were available. And that was my first real exposure to research design and methods. I found myself in a behavioral sciences research lab, which is sort of interesting because that's, where my intersection lies a lot, is behavioral health research with oral health research. While I was there, I conducted focus groups. I learned about research methodology. And, I left college for dental school and thought that I was leaving the research behind me because it was mostly a job. Although I liked it, it wasn't something that I thought that I would continue to pursue. But I got a job when I was in dental school because I thought I was going to go into oral surgery initially. So I started working in the office in the faculty practice for oral surgery, just doing, cleaning instruments, assisting clinically, doing that kind of stuff. And then one of the faculty came up and asked if I would be interested in working as a research assistant because he was starting a new research project. So that was my second exposure, not planned at all. But again, I got experience in research design and methods, focused project on implantology, But it was my first real exposure to grant writing and clinical research this time, which I found very exciting and interesting. But I decided that I didn't want to go into oral surgery. I really wanted to be a general practitioner. I wanted, the reason I went into dentistry was I wanted to have a patient pool that I, followed over time, and oral surgery wasn't going to give me that. So in my GPR, I was immersed in clinical care. I had no real research opportunities, but I was working at VA here in West Roxbury and Brockton. They were Harvard affiliated GPRs, and I really became interested in access to care and oral health inequities through that experience. And about that same time that I was getting ready to finish my GPR, BU and Harvard sent around options or opportunities that they had to apply for a HRSA-supported geriatric dentistry and medicine fellowship. And this allowed you to get your MPH, which I was very excited about, to get more background in geriatrics. And as part of that, I had to do a small mentored research project. And this was my first exposure to health services research, working on Medicare supplement programs and the impact of dental pieces, the dental component of those supplement programs. And then when I when I finished the fellowship, BU recruited me to join their faculty. And at that point, it was really one of the pivotal, I think, things that happened in my entire career is when I joined in 1996, my now mentor, Dr. Raul Garcia, joined at the same time. And I became part of his department because I had a background, I had an MPH. Some of the things I was working on were related to his areas of interest. And he helped me to actually open my eyes to grants and career opportunities that I didn't know existed, like the K-23 award. And so with his mentorship and great amount of assistance, I applied and received a K-23 around oral conditions and health outcomes in frail elders, really building on that home medical service and the network of long-term care facilities that were part of the fellowship that I worked within. But I also was really interested in the other end of the age spectrum, trying to prevent disease in young kids. And so created also a collaboration with public health nurses that were part of a home visiting program. So both of these really focused on bringing services to really at-risk individuals in their homes or where they were living, and really trying to see if visiting public health nurses in that perinatal period could make a difference in early childhood caries. And then, as I became more experienced, we took the Healthy Baby, Healthy Child program, and I received a CDC Oral Health Small Grants program. I got some experience writing foundation grants. And then the sort of next, I would say, pivotal moment happened in my career was when the NIDCR released their request for proposals for the Centers for Research to reduce oral health disparities. And so Dr. Garcia decided to apply for one of these awards. And that was my first exposure to a big center grant. That really took, I helped, with some of the grunt work of pulling things together, but I also helped develop the community engagement core and became a co-director of that, based on all the work that I had done in the community and developing partnerships. And after we were funded, I actually wrote a successful pilot project grant, which actually then formed the basis for being a PI on one of the main RCTs that were part of the second round of the disparity centers. So we were funded in the second round as well, with both Dr. Garcia and myself as co-directors of the center, and me being a co-PI on one of the main RCTs. So that really, those experiences during this like 15 years, these disparity centers were 7 years of funding each, was really pivotal to my professional development in research. It gave me a great wealth of experience, as well as a very large network that I could draw on of colleagues of many, many different disciplines across the country. And our center themes were really revolve around, and remember, this was like 25 years ago, where we were really promoting, doing oral health research in non-dental settings. We were one of the first to really look at the well-child medical visits and in community health clinics and tertiary care hospitals, looking at public housing developments as a site, and having peer public housing residents actually deliver the interventions, medical care providers, nurses. That's really been a theme of my work, as well as the CREED Center. And you can see the two main trials that were part of the second round of disparity centers. So ours was oral health advocates in public housing, as I alluded to. And so really throughout my career, I have focused on vulnerable populations and health inequities, really the two ends of the age spectrum, from the very young children to frail and functionally dependent elders. And within those groups, really focusing on racial and ethnic minorities, those who are living below the federal poverty level. And then I didn't put it in the slides already, or the previous slides, but I also was doing some work with HRSA in the area of HIV and access to care. It wasn't research, it was more educational work. But that actually formed the foundation for a lot of my current work. We're currently, and I'll talk about each of these briefly, working with Head Start sites to expand models of oral health care delivery. Still working in pediatric medical clinics, just in a little bit different context. Integrating HIV testing into dental school clinics, private dental practices, as well as community health center dental clinics. So really, and you can see the long-term care, co-designing interventions. All of my work is really at the intersection of oral health and total health care or healthcare delivery settings. The little work that we do in dental clinics are really primarily focused on bringing medical care into dental clinics. So we're working on Head Start teachers as well. This is, I alluded to earlier, community-based approaches, which I think are as equally important to getting access to at-risk populations. So really trying to look at work that we've done in other countries, work that's been done in the Indian Health Service, and try and push models that we know have been successful in other settings, and see if we can push the envelope here in terms of policy through the research that we do can actually inform changes in policy that would need to happen in terms of scope of practice and financing. We also have the I-Smile program. So we had success in our medical oral health integration projects in the disparity centers, but physician time and just the whole physician team time in primary care medicine and pediatrics was becoming so precious that it was really difficult for counseling to happen. So we developed a text messaging program to help deliver those counseling messages, which we were able to get improvements in parent behaviors, including taking children to the dentist and increased toothbrushing, especially with fluoridated toothpaste. I mentioned my work around HIV. We are, in addition to the things that I have previously mentioned, we're also were funded to help identify factors to improve medical and dental health care among people with HIV. And as part of the Boston Providence Center for AIDS Research, the new round of funding, we were able to pull together a very multidisciplinary oral health and HIV scientific working group. So we have from basic science all the way to clinicians and community members who are part of that working group. We've had just 2 meetings, but so far it's been very fruitful. And then similar to what we're doing in Head Start settings, we know that the long-term care initiatives have been successful in the short term, but haven't really shown any long-term impact in terms of clinical outcomes. So really working to co-design something that will be sustainable and be able to truly be integrated into the existing workflow. So we're currently working on developing that model, which we hope to get funding in the future to actually test. And then this is the one that's really in the dental clinics, really trying to just push, figure out a way to incentivize dentists to be able to place more sealants in private practice settings and community healthcare settings, in dental clinic settings, because we still have a long way to go in using this evidence-based preventive service. And then the importance of really translating what we've learned in our work into actual care delivery and program delivery, both within this country, and I have here different initiatives that we have globally to try to improve oral health. All of these examples are actually in young children. And then, thinking about, is this a good career move for those of you that are in the beginning of your career? The NIDCR strategic plan that goes through 2026 really has this topic woven into its vision and mission. So it's deeply devoted to integration of oral health and total health research. In fact, it's its strategic priority #1, as you can see from this slide, although I would also argue that it's truly interwoven into the other strategic priorities, especially if you look at the examples that are woven throughout the strategic plan. And I just chose a couple of examples from the strategic plan of the bold predictions, where the NIDCR thinks that we can be if we are innovative in the research that we do in this area. And I think that working together in a multidisciplinary way and engaging the health professions and behavioral scientists and really all disciplines of science together, and being strategic in the settings that we work in to answer questions collaboratively is really the way that we're going to be able to impact and or the oral health inequities that we currently see and improve the overall quality of life of the people in our country. So that's our introduction, the last of my formal statements.